All right, guys, we're going to go ahead and get started. Again, some housekeeping things. Like Fran already mentioned, if you guys are talking, try and keep your voices down because they can pick it up on the Zoom call. My name is Kevin. Most of you know me. I want to start out with saying thank you to Fran for putting this together. We've been talking about this for a long time, and it would not happen without Fran's help and all of you. So I appreciate you guys being here. The goal of this class is this specific lecture is to introduce the techniques and terminology. This is a skills thing. You're not going to learn this in a lecture, but we're going to introduce you to the techniques and the terminology that you're going to apply later on when you get into the skills lab and when you're going through your certification process. Real quick, people on Zoom, can you hear me okay? Thumbs up to Fran if so. Okay. All right. So again, we're going to be talking about techniques and terminology. Some of this, if you get to the end of this lecture and some of these things aren't clear, we'll go over it again when we get into the skills portion. And then we can meet individually as well. So it is a skill, though. It's something you're going to have to practice in order to become proficient in. And it's difficult. I'm not going to say it's easy, but once you figure it out, it feels really satisfying to go in there. You find that vein you're looking for, and you're placing that IV. It's definitely one of the highlights of my shifts when I get to do it. So I want to encourage everyone to become proficient. So let's go over the plan. Hold on here. So this was my plan. 8 years ago. He saw the picture this morning, and I told him that I cut out his naked butt. So he was very happy with that. All right, the plan. So what are we looking for? We're looking for veins. We want to know where to find them. We're going to go over some anatomy and some rules. Anytime we're talking about IV insertion, we have to go back over some of the basics. Okay? We'll talk about the ultrasound machine, the different components, how to set it up, and what we're looking at on the screen. We'll look at the supplies we're going to need, patient prep. We'll go over Jtip, line of sight, to help our hand-eye coordination. A lot of this is hand-eye coordination. Those video gamers have a heads up on that. Their hands are on the buttons, but their eyes are on the screen. We're going to use that same kind of technique placing these IVs. But it's something that can be learned and we can get better at. We'll go over some basic techniques, the wink-wink and the wiggle-wiggle. And then the lights on and lights off technique. We'll go over some of the complications that can come out of any IV insertion, but especially with ultrasound. Talk about some keys to success and your path to certification. So let's get started. Veins and where to find them. So I apologize for the image quality. It's always a challenge with the technology. It looks great on my screen, but it doesn't look so great on yours. But this image here, we can see the arm. I've gotten rid of all kind of the extra tissue there to make it easily identifiable. So we're looking for our veins, and we're going to start in our wrist and work our way all the way up the arm. Radial, ulnar, median, the basilic, the cephalic, the median cubital, the accessory cephalic, the basilic and the upper arm, the brachial in the upper arm, and then the cephalic in the upper arm. I don't expect you to know the names. I want you to kind of, and you guys know this, you guys were in the ED, we're really good at placing IVs. And we do that because we practice over and over again, and you guys know where the veins live. But I just wanted to kind of refresh everyone here as to where our targets are. We also need to be thinking about the nerves, especially with the ultrasound IV. We now have the opportunity to look under the skin. We can see the tissue there. Veins are hard to see. The nerves are hard to identify. But so we need to pay attention to where our nerves kind of come to the surface and when they're running alongside our arteries and our veins. This is especially true when we look down here at the wrist. See my laser pointer down here in the wrist, when they run along the ulnar and the radial arteries and veins. And then again up here in the upper arm the median and ulnar nerves will run right along the blood vessels there as well, the brachial and the basilic. Veins and arteries and nerves like to run in triads. It's not always the case, but they do in very predictable locations. And they do that down here in the wrist. Okay, so ideally we're going to be avoiding these locations. If we see on our ultrasound image, we see a vein and an artery running right next to each other, I want you to assume that there's a nerve running right there. And so we're going to avoid that location, okay, even if we can't see that nerve. We'll talk about nerves here a little bit more in a minute. Okay, so now I'm going to throw in some tissue here. And to show you those veins that are running on top of the tissue. So this is superficial veins, and these are our targets here. We don't want to be driving our needle through muscle tissue. We want to be shooting for those relatively shallow veins. And we can see them here. Back of the hand, we've got the accessory cephalic, the basilic, and the cephalic. Cephalic is one of my favorites. It's one that's not often chosen, but it's really nice to, because it hasn't been chosen often in a traditional sense with the ultrasound, it makes it a good target. And then we also need to be looking at the saphenous, the small saphenous, and the greater saphenous in the legs. And we're only going to be doing this in our kiddos that aren't going to be walking. Okay, we want to exhaust all of our options in the upper extremities before we move down to the lower extremities.
Attention all departments, please return all surplus pneumatic tubes to station 0. Attention all departments, please return all surplus pneumatic tubes to station 0.
Okay, so we're going to talk about some vessel anatomy here. Again, just some basic stuff I want people to pay attention to. Blood vessels have 3 major layers. The tunica adventitia, which is that outer layer. It's got the connective tissue that's supportive. The tunica media, that's where the muscle and the elasticity comes in. That's where we have that vasoconstriction and the vasodilation. That's where those muscles come into play there. And those muscles are present in both the artery and the vein, but more pronounced in the artery. This becomes an issue when we're using our buffered lidocaine. So something to think about. And then we have my favorite layer, the endothelium, that tunica intima. It's a single layer of flat cells lining the blood vessels. Welcome, Meg.
Sorry, David.
So these are our blood vessels here. We have arteries and veins. We're going to be looking at these vessels in a couple different views. We're going to do a cross-sectional view and a longitudinal view. Down here is our longitudinal view. We're going to be splitting the vein down the middle, and we're going to see our the top wall of our blood vessel and the lower wall of our blood vessel. And then we're also going to take a cross-sectional slice through that blood vessel as well. So be thinking about this when we talk about orientation, like a cross-sectional view and our longitudinal view. Here is our cross-sectional view. Okay, we've got our lumen in the middle. That's where we're shooting for. And then we have our longitudinal view where we can see the upper wall and the lower wall of our blood vessel. And again, I've kind of identified the 3 major layers of a blood vessel. So injury to that endothelial layer is where we're going to get our clot formation. It's going to start that cascade. And we want to, anytime we access a vein where there's a chance we're going to introduce a thrombus formation, it's something to keep on our radar, something we can watch for, and we can actually see with our ultrasound machine. So damage to that endothelial cell starts that cascade, depositing fibrin as a platelet plug there to stop that leak. This can come from the catheter tip is actually lying right up against that, the endothelial wall, and causing irritation and wearing away that single layer of tissue. Also, the vesicant or an irritant that we're infusing right up against the wall there can cause blistering or degradation of the endothelial cells. And then if we're going at it multiple times, we're poking over and over again, trying to find that spot, we're increasing our risk for thrombus formation. Okay. All right. And if we do see these thrombus formation, you know, it has the potential for becoming a DVT if we're in a deeper blood vessel. Okay, so thrombus formation, and this is something I want to think about, especially for us in the ED. You know, we like to go big or go home. We like those big IV catheters. But it's something to think about because the larger our catheter, that we're going to change the blood flow dynamics inside the vessel. In this image here, B here, we've got the diameter of our blood vessel, and then we've got the diameter of our catheter. And this one here in A, we've got our catheter in the center, and then we've got our top and lower wall of the blood vessel. This little diagram here shows the flow dynamics relative to the walls of the catheter and relative to the wall of the blood vessel. So if we have a really big catheter in a really tiny vein, we're slowing things down. We're going to increase our likelihood for thrombus formation. So we ideally want to use the smallest catheter possible for what we need to do. So we're going to tamp down that go big or go home kind of idea in some sense. Okay, because a lot of times we're looking at hard sticks. We're looking for those smaller blood vessels. We don't want to throw a 20 into a nice tiny little vein. Okay, this is an important topic that we're going to be talking about over and over throughout this lecture, vessel preservation. We're working with kids. They need this access for the rest of their life. This is the vascular access team. They're big proponents of this, that we preserve. We focus on preserving those blood vessels for the lifetime of our patients. So super important in pediatrics. We're not going to go in the upper arm, okay? A couple different reasons we want to save those for later on in life. In the adult world, we love going up here in the higher up in the arm, the nice big healthy blood vessels that haven't been used and abused. We want to stay away from flexion points, and we want to avoid from going deep. Okay, and I'll talk about what deep means a little bit later on in the lecture. When we go up here in the arm, they're nice big blood vessels, but we also we have arteries that are running in there, close proximity to our veins, along with those nerves that we want to try and avoid. And like I said, we're going to stay away from the nerves. Okay. This is also important with our chronic kids, especially our sickle cell kids, that get accessed over and over and over again. The only thing that's left is in that little pinky that we're shooting for. With the ultrasound, we have the opportunity to look elsewhere in their body, and so we need to be thinking about not overusing certain areas. But with repeated accessing, we can develop some stenosis or scarring. And it causes, like you'll see with the ultrasound, when you play around with it, you'll try and collapse a blood vessel and it won't happen. And that's usually because of scar tissue. They also cause spider veins to develop, accessory circulation to maintain blood flow to tissue. This image here is a casting of blood vessels in a patient's arm. So you can see where those capillary networks kind of congregate. Pretty cool. All right, we've made it to the part here where we're going to introduce our ultrasound machines. Okay, in our department, we have two machines. We've got the big one here that lives in the attending's office. And we've got the smaller one that lives in the anteroom between trauma 1 and trauma 2. This is a personal pet peeve, and the more you do ultrasound IVs, this will become one of your pet peeves, I hope, is not charging. Okay, you go in to grab a machine and the machine is dead. Okay, so when you're putting things back in their rightful place, way down here at the bottom, there's a charging dock there and a charging dock there. Please plug those machines back in. Okay, and make sure that their machines are clean too. Okay. All right, some technical details with the ultrasound. We're using sound. We're passing sound through tissue. And the quality of that sound and the quality of the image changes depending on which probe we use. And we use the probe, this 6 megahertz to 13 megahertz sound waves from this linear probe here. There was a lecture just the other day. Kevin Whitelaw did using the curvilinear probe. It uses lower frequency sound, travels deeper, and when we go lower with our frequency, we get less detail. So this probe here is the one that we like to use for ultrasound because it gives us those nice high resolution images. The problem, the downside is it doesn't go very deep, but that's okay for us because we're looking shallow in the tissue. Okay. I'm going to flip this probe over here, and I'm going to show you our sound waves kind of travel away from our probe, just like that. Okay, they're traveling through. And as the sound wave travels through the tissue, things are sent back to that probe. We process those images into things we see on our ultrasound screen. If we rotate our probe, so this is the side view of that beam of sound that's traveling through. So in one direction, we've got a nice wide beam. In the other one, we've got a nice narrow beam. Okay, so I want you to be thinking about that when you're moving your probe. It looks like you got this nice big picture, but if you were to rotate that probe, it's really, we're only catching like that much tissue in our beam. Some things about our ultrasound probe. These are going to be key for placing that IV. That mark on the left here, use my laser pointer here, that's our center line indicator. We'll talk about that more in a minute. And then also this little orientation marker here on the side of the probe. So our center line indicator corresponds to the center line on our screen. And this is super important for guiding our IV into our vein, because our vein is going to be right in here, right below that center, or right on that center line. That's going to be our guide when we introduce our needle. That little orientation marker on the side of the probe needs to correspond to that little mark there up in the upper left-hand corner of our screen. So when we're holding our probe, that little dimple is going to be to our left, the patient's right. But you don't have to remember that. Just make sure the little marker is on the left of the probe, is on the same side as the screen that you're looking at. Okay, some of the buttons that come with our ultrasound machines, and again, we've got two different types. So the nice big one here, our gain, which controls the brightness of our screen. Up here, the brightness of our image is down here along that bottom axis, and it's a slider button. We'll move it right or left, and that'll adjust the brightness. On our smaller, older machine, there's a knob here that says gain. It's indicated by that orange marker right there. That's the knob we're going to be rotating to adjust the gain on our smaller machine. For adjusting the depth of our image, on this other axis here, it's another slider, and we're going to be moving that up and down to adjust the depth of our image up here on our screen. And again, over here on this side, we're going to be using this button here to adjust our depth to where we want it. Now, we had some technical difficulties here. There's actually a movie here kind of showing you how to use that and how sliding those buttons back and forth adjust our image. And it doesn't really play well over Zoom. So I'm just actually going to kind of walk us through it here. So we can see on this axis here, way up here at the surface up here by our skin, that's our 0 mark. And then as we go down this axis, this is the depth of tissue. So that first marker there is 0.5 centimeters. The second one is 1 centimeter, and then the next mark beyond that is 1.5. Okay. Again, we slide this marker here up and down to adjust the depth. And I'll talk to you about the optimal depth here in just a bit. Ideally, we want to adjust that depth to 1.5 centimeters. That's our window. And then also adjusting the brightness of the screen, or the brightness of our image here, we're going to be using this little marker right down here, sliding it from left to right. And this is based on personal preference and image quality that you're getting with that specific patient. You're going to adjust that back and forth. I'm going to let it play through here. You may or may not be able to hear it, but follow my fingers here. You'll be able to see me touch the screen. I'm going to adjust the depth here in just a second. I'm going to put my finger on the screen. move it all the way up to the top, and that gives us our 1.5 centimeter window. Okay. And then adjusting that slider knob on the bottom, adjusting our gain. You can see the image up top gets darker when I go to the left and brighter when I move it to the right. We'll play around with these in the skills lab. Okay. Okay. Prepping our machine. We need to cover up our probe. We're dealing with blood here, so bloodborne pathogens. We need to make sure we protect our patients, and we also need to make sure we protect our probe as well. I know oftentimes in trauma, they're taking those probes and they're moving them all over the patient, but they're not really necessarily introduced to blood often. When we can, we want to make sure we have a probe cover over our probe. And we use the tegaderm primarily. We've talked to vascular access, and we may be getting access to some probe covers to be using for IV insertions. So we want to make sure we cover up our probe with the tegaderm. And when we apply that, we want to make sure it's a nice, even application. We don't want any bubbles underneath that tegaderm, because that's going to decrease the quality of our image on the screen. All right, some supplies that we need for this. We need some extra supplies than we would normally use for our traditional IV insertion. So we want to use the some sterile gel. We have, at the time I took this picture, this is what we had in the department. We now have the Surgilube, and the Surgilube works well. It's a nice small packet. And then we actually found some old sterile ultrasound gel as well. So they're in that that small cubby in between trauma 1 and trauma 2, up in the cabinets. Okay. So we've got our traditional stuff set up here. We've got this tegaderm here that we're going to use to cover our probe. I really like having a small set of sterile gauze there. Ultrasound is messy. You've all seen it. There's gel everywhere, and when it gets on your fingers and it makes everything slippery. Having the nice sterile gauze there, you can wipe away that excess gel. You can also, if there's bleeding, which more often than not there will be, you can use that gel, the sterile gauze there to cover it up. And then we also have our Jtip here in the middle, and I'm going to advocate for trying that out. I know people are a little bit hesitant to use the Jtip and the buffered lidocaine. Sometimes when we're using it on our superficial blood vessels, because it's in such close proximity to that blood vessel, we get a lot of vasoconstriction, or even people blow. With the ultrasound, we're looking at vessels that are running a little bit deeper. So when we use the Jtip, we're blowing the buffered lidocaine underneath the skin. It's further away from that blood vessel. What I have found over the last few months of using it, we actually get very little vasoconstriction. So we get all the benefit of numbing up a nice area where our needle is going to go in. The patient is less hesitant. We can pass through that area, and it maintains the integrity of our blood vessel. So I'm not saying it's mandatory, but I would advocate for trying it out. Okay. And then we also have longer needles. Okay, these needles also live in that small room in between trauma 1 and trauma 2, up in the cabinet there. Our 20 gauge is 1 3/4 inches long. It's a nice long catheter. But I also want you to look at the diameter of that catheter there, 1.1 millimeters. Okay, and 0.9 millimeters and 0.7 millimeters for our 24 gauge. And that 24 gauge is 1 1/4 inches long. Okay, again, our goal is to get at least 50% of our catheter inside the vein. These will help us do that. Okay, patient prep. Again, I talked about hand-eye coordination, so it's super important to kind of help facilitate that hand-eye coordination. Thanks to Aubrey and Rebecca here for being my models. So we want to make sure we can line up our ultrasound machine in 2 different ways. This one is across the patient, and this one is on the side. But ideally, we want kind of a line of sight. We want to have our needle insertion going towards our screen. Okay, that's going to help us guide everything along. So our rooms are small. If you can get access to a bigger room, I advocate for that. Makes things a whole lot easier when you're using the ultrasound machines. You definitely do not want to be looking over your shoulder at the screen and trying to move your needle in the opposite direction. It just does not help facilitate an easy introduction of that catheter. All right, so supplies are ready. Our patient is set up. Our machine is set up. Let's go find a vein. So what are we looking at? So when we pass that sound, it travels through the tissue and it sends back information to the probe that we process into the image that we see on the screen. And so blood and water are poor reflectors. Okay, they show up dark on our screen or black. Bone or metal, the ultrasound waves can't travel through that, so they're highly refractive. And you'll also hear the term echogenic, like they create an echo. They send those sound waves back as nice, bright images. They appear as white. In this image down here, you can see what we think are two blood vessels right down there. They're nice and black. And then we see these other highly reflective white. That's the fascia that runs through that creates our compartments around veins and nerves, muscle tissue, creating layers in the skin. So down here, we've got some muscle tissue. So soft tissue, so this stuff down here, it varies in reflectance. And so we're going to get all kinds of information when we're trying to insert our needle into the tissue. So we need to be thinking about that. Hi, Ashton. Welcome. All right. So nerves. So again, like I said before, nerves can be really hard to identify on an ultrasound image. And our kids are super tiny. They're going to have super tiny veins. It's going to be difficult to see. Now, if you're looking at adults and you're looking up in the arm, sometimes you can see those nice big honeycomb structures, grape-like structures in the arms, but it's really hard to identify. And that's why it's important to know when we're more likely to run into those nerves, definitely down at the wrist and then higher up in the arm, okay? And if we see two blood vessels running together, and you see this kind of, you can see this kind of compartment here. There's kind of a triangular compartment here. That's a great place for that triad that I was talking about earlier, the artery, the vein, and the nerve running alongside each other. So I want you, when you see something like this and you're applying some pressure and you use one's a vein and one's an artery, I want you to avoid this area, okay? Stay away from that. We do not want to hit a nerve. Okay, again, I'm going to talk about veins are going to be round objects with a blackish center, easily collapsed. And I'll show you here in the next couple slides here what those look like on the ultrasound. Arteries are going to be pulsatile. Nerves, again, like I said, difficult to visualize. They look like honeycomb structure or a grape-like structure. And again, it's important to know your anatomy and where you're more likely to run into those. Needle tips, it's metal. It's going to be highly reflective. It's going to show up as a bright white light. And we're going to use that to our advantage when we talk about our lights on, lights off technique when we're introducing a needle into the tissue. But not every bright light on the screen is our needle tip, okay? And we'll talk about the methods for differentiating things, and we're using the wiggle technique. But if you look down here in this image down here, you've got 3 different bright images, and any of those could be your needle tip. Okay, and that's where we're going to be talking about using the wiggle technique to differentiate our needle tip from the surrounding structures. All right. Now, again, technical issues here on my screen. This is a beautiful image. Okay. On yours, it might not be so. So we've got our probe on. We found a vessel. Is it an artery or is it a vein? On the left here, we're putting a little bit of pressure and we see that nice little heartbeat running there. Boom, 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 boom. On the right, we're putting pressure down on the vessel and we get the wink. Okay. All right. So we've found our vessel. We figured out, is it an artery? Is it a vein? We want to measure that vessel. And again, on this image here, you can see, here's our depth here, 0.51, 1.5 centimeters. Okay, we can use that scale to give us an idea, an estimate as to what the diameter is of our blood vessel here. Okay, so that's a nice, relatively large blood vessel for us to shoot for, about 0.25 centimeters. Okay, so that's going to dictate what size catheter we're going to be using. All right, what's the best depth for getting that IV in? Okay, so the deeper we go, our success rate drops considerably. Our goal is to find that blood vessel in this first 0.5 centimeters. Okay, that is ultimately our goal. We do not want to be going below 1 centimeter. Okay, this is an important point. The deeper we go, the more catheter we leave in the tissue and not in the vein. Okay, and then our success rate for actually throwing the catheter in the vessel goes down significantly the deeper we go. Okay. All right, so we found our vessel. So we applied our probe to the arm, and this is what we see. At that point on our arm, we've got a nice round blood vessel, and it looks pretty good. All right, we've collapsed it, it winked at us. But what we need to do is we need to actually look at the path that the catheter is going to follow. So we're going to take our probe and we're going to go up and down the arm, and we're going to follow that path and look for the best place to insert that IV. And we want to make sure that when we're advancing our catheter, we've got a nice clear path. We don't have scar tissue, we don't have stenosis in some area, or we're coming up against a bifurcation. Okay, we'll move along and like you got a nice big juicy round dot, and then all of a sudden it goes away and you end up with two other dots that are further apart. And that's fine. Everyone's anatomy is a little bit different. And so we want to identify what our path is going to be. When I was playing around with the ultrasound the other day, someone pointed out, well, which hand holds what? And I hadn't thought about that. So, or at least talking about it anyways. So our non-dominant hand is going to hold the probe, and our dominant hand is going to hold the needle. Who's going to hold the patient? So find a friend. Okay. It's super important. You're gonna need someone to help hold the arm. In the older kids, the sickle cell people, they're usually able to keep their arm still. You may be able to get away with just doing it solo, but I encourage you, especially in the beginning, to get a friend in there. You guys can talk about what you're seeing on the screen. They can help you identify things. They can remind you of what to avoid, what to go for. They can encourage you on your path. So get a friend. All right. Holding the probe. Aubrey got her nails done specifically for this image. So you can't really see it on this image here, but they do look really nice on my screen. So holding the probe. Now her technique is great. I love the way she's holding that probe. Her thumb and index finger are holding that probe, and her other fingers are there stabilizing it on the arm. So she can move up and down that arm, following the path of that blood vessel, and she's got control. She's keeping the probe perpendicular to the skin. So that's a technique I want to try. You're not going to hold this like you're holding an udder, Sam, all right? Delicate touch, all right? Delicate. Sorry, Sam. Didn't mean to throw you on the brush. Okay, so another thing that often happens when we're first starting out with the getting used to that hand-eye coordination and holding onto the probe is the amount of pressure we're applying on the probe to the arm. And so we're going to want to wink that vein. Okay, so when I talk about applying pressure, I'm talking about this up and down motion, the amount of pressure. Often when we get in there, we're nervous. We're like holding that probe on that. We want to find that vein. We're like holding on real tight, and we don't see anything. And we're like, man, there's no veins here at all. But the reality is, if we lighten up our pressure on that probe, we allow that vein to expand, and like all of a sudden, we've got the mother lode. Okay, so when you get into the skills lab, you're holding the probe, play around with pressure, see how it feels. What's the ideal point of holding that probe? Okay, now everything's set up.
One question.
Yeah.
Do you recommend putting a tourniquet on while you're looking?
Yes.
Or? Okay.
Yes. Yeah. Put the tourniquet on. You want those blood vessels nice and big and plump. We kind of want to know what our target. And now we can always take it off, get everything ready to go, clean everything up before we actually do our needle insertion. But yeah, when we're when we're looking for that vessel, put that tourniquet on. Good point. I should have mentioned that. Okay, so we've got our supplies, we've got our machine set up, we've got our patient set up. We found our vessel, and now we're going to talk about introducing the needle. Okay. So again, I talked about our probe and this little marker right here. That marker is going to correspond to our center line image on the screen. Okay. We are looking at this. Okay. We're taking our needle and we're going to aim for that spot right there on our probe. Okay. When we look at it from the lateral view, that's how it's going to look. Okay. That center line and that marker help guide us in to that vein that we got nice and lined up on the image. We need to think about angle of insertion. Okay, when we have those nice superficial veins, we're coming in relatively shallow. We know we're going to get in there relatively quickly. We're going to have a lot of catheter in the vein we want to go. Sometimes when we're going a little bit deeper, we're going to use a steeper angle, okay, to get through our tissue and into our vein. Because if you look here, if you compare the amount of catheter that is in the vein relative to the angle of insertion, this one here, we've got a lot of catheter in the tissue and relatively little catheter in the vein, okay? So there's no hard and fast, okay? But I want you to be thinking about angle of insertion, and it's going to change as we go into the vessel, and I'll show you here in the next slide. So if we come in at a nice steep angle, all right, we're in our vein here, that's great, right? But if we try and advance our catheter off the needle at this angle here, and we hit that back wall, there's that buckle right there. That's a hard angle for that catheter to kind of maneuver. And we'll feel that sometimes when we're advancing and we'll get that little bit of resistance, and we'll even get that buckle sensation. You know, you feel like, oh, something's off. That's a sensation. So we can start our angle into the vein at a relatively steep angle, and then we can shallow out. Because when we shallow out, let's say we get in there, and then we're advancing our catheter off at that angle, it's nice and smooth. Okay, so be thinking about changing our angle as we go into the vessel. So, all right, we're here at the lights on, lights off technique. Okay, I've got my probe set up over here. I've got my needle under the skin, and I've got my target vessel down here. There's the top wall of the blood vessel and the bottom wall of the blood vessel. My eyes are on the screen. Okay, I've got my probe, I've got my skin, I've got all this tissue that I'm going to be going through, and I've got my vessel down here. It's all lined up. Now, I want you to focus over here just for a second. I'm not going to move my probe, but I'm going to move my needle. Watch the needle move. The needle is going to move into the beam, the ultrasound beam. And what's going to show up on my screen is a nice white light. That's the lights on. Okay? I'm going to make a small movement up the arm. I'm going to move my probe, not my needle, move my probe. My light goes off. Okay? Move my needle into the beam, move my probe, move my needle as we're walking our way down. And we're going to walk our way all the way down to the vessel. Okay? The lights on, lights off technique. Small movements, not big ones, small movements. And you'll get to practice this in the skills lab and on an individual basis. Okay? I'm going to take a jump here. I'm going to come down here to the vessel. All right. So we've got our needle and it's into that wall. Here's our image, right? This is what we can see. We get a flash in our needle. We're doing our happy dance. We're like, yeah, baby, I'm going to slide that catheter off. Wait, okay? Because look, we can't see it necessarily on the ultrasound image. We see their tip, all right? And our tip is in the vessel, right? But our catheter is still in that wall, okay? We have the opportunity to walk that needle and catheter in. Let's take advantage of it, okay? So again, we're going to continue with our lights on, lights off technique. Our focus is on the screen, not on that flash that we just got in our needle. So we're going to move our probe, move our needle, move our probe. The light goes off. The light comes back on again, okay? Small incremental movements. Now we get to the wiggle wiggle. and I'm not talking about a dance move. All right, I've seen the videos. We're talking about making small wiggles with the needle. Okay, it's small right and left movements with the needle tip. All right. One of the challenges when you first start out, you've got your probe there and you've got your needle underneath the skin. You're like, where the heck is my needle tip? All right, you cannot find it for the love of God. You're like, man, you're freaking out. You're moving things around, you know, it's stressful. Slow down. Okay. We're going to make a small incremental movement with our needle, and we're going to see a white light that shows up on our screen. And we're like, okay, that might be our tip, might not, right? Because it could be there's other information there on the screen that might distract us. Or what we're going to introduce is the wiggle wiggle. We're going to make small movements with our needle tip, and this is what we see on the screen. Let's come back here. We're going to see this. Everyone see that? The little white dots are moving back and forth. Okay. That's the wiggle wiggle. So we get underneath the skin. The first thing we want to do is we want to try and find that tip. We're going to use a little wiggle wiggle technique. Right? We can use that wiggle wiggle technique at any point when we're putting this needle through. So now I'm going to jump ahead a little bit. We're going to get down here to the vein. I don't have a white light. Where's my tip? I'm going to advance my needle a little bit. There's my tip. But is that really my tip? We do the wiggle wiggle again, okay? So we're going back and forth. We wiggle our tip. All right, I'm going to show you a little video here. There's no sound here. I'm just going to let you watch the screen, and I want you to keep your eyes open for the lights on, lights off, and the wiggle wiggle. Okay. All right, now we're gonna go back. We're gonna watch that video one more time, and I'm gonna talk our way through it. Okay, so look up here. Our light comes on. I'm gonna move my probe. Light goes away. Move my needle. Light comes on. Getting close to the vessel. I'm through the vessel wall there. Okay. Little wiggle wiggle. That's my needle tip. Now I'm going to move my probe, move my needle, move my probe, move my needle, move my probe, needle, and walk that in as far as possible. And we'll finish off with the wiggle wiggle. All right. So now, what does this look like from a longitudinal view? Okay. So up here, we've got our skin up here. We've got the upper wall of our blood vessel, the lower wall that kind of tapers off our image here. But there's our needle and our catheter coming through that wall, and it's right there in the center of our vein. Okay. How did I get this image? I rotated my probe, and this is really difficult to do. Okay, you guys can play around with it. It's a little bit more challenging to kind of get this image. But if you see here on the right hand side of the screen, I rotated my probe, so we're getting from a cross-sectional view to a longitudinal view, and that will show us exactly where our needle tip is and our catheter. At this point, we would advance our catheter off the needle. We also need to introduce the term of fanning the probe. Okay, what do I mean by fanning the probe? So ideally, we're holding that probe perpendicular to the skin. We can see our needle tip, and we have our nice bright light on the screen. But if we, without moving the probe up or down the arm, we fan that probe, we still get that white light on the screen, but we're not looking at our tip. Okay, we're further up the catheter, we're looking at the bevel. And if you go the other direction, we're right above our needle tip, but we're not capturing the tip of our catheter here. So I want you to think about this and pay attention to where our probe is and making sure that it's perpendicular to the skin. All right. So we made it through the techniques section. We're going to talk about some of the complications that can come up with accessing an artery. It has happened. I have done it. We don't mean to do it, but if it does happen, we need to remove the catheter and we need to apply pressure, manual pressure, for 4 to 6 minutes, followed by a pressure dressing for 4 to 6 hours, and we're going to monitor circulation. Okay, what happens when we hit that nerve? Now, some people, it's happened to me actually. I went to an acupuncturist and they found that nerve, and man, that probably hurt. So when we do hit nerves, the patient will let you know that you hit a nerve. Again, we might not be able to see it, but we're going to assume relative to the location on the arm and our patient's response as to whether we've hit a nerve. Okay, we're going to try and avoid those high likely areas of the arm. It can cause severe pain, numbness, tingling. We want to remove the catheter promptly. If we actually, transect one of those nerves, it can actually cause long-term issues of pain, weakness, tingling, and possible paralysis. Okay, so something to be thinking about. Phlebitis, angry vein. Okay, again, anytime we talk about IVs, we're going to talk about some of the basics. We want to pay attention after we put it in. We want to think about what we're inserting into that through that catheter. Is it going to be an irritant? And assessing that over time. Thrombosis. There are times when we may come across this. We're looking at our vein, we're exploring that vessel, and we'll come across something that looks like that. And we try to apply a little bit of pressure, and it won't collapse. It'll collapse upstream and downstream, but it won't collapse over that vessel. If we see those thrombosis, we're going to avoid that location. We're going to find someplace else to go looking for it, because we can potentially dislodge that and make things worse. All right, we're going to summarize things here real quick. All right, we're going to prepare our machine. Let me move my pointer. We're going to put that probe cover on. We're going to put that tegaderm over the probe. We're going to set up all of our supplies. We're going to line up our patient and our machine. We're going to differentiate an artery from a vein using the wink-wink technique. We're going to look at the size and the depth. We're not going to go beyond 1 centimeter. And we're going to avoid, we're going to have a nice clear path. We're going to avoid flexion points. And we're going to find the ideal. We're going to think about the angle of insertion. We're going to find our tip using the wiggle-wiggle. And then we're going to use our lights on, lights off technique to advance that needle into the vein. Okay, we'll get to that point. We're happy campers, right? Okay, keys to success. Be patient with yourself. You are going to miss, but I don't want you to give up. Like I said at the start of this is a skill. We are all really good at inserting IVs in that traditional format. The reason why we are so good at it is because we do it all the time. We practice over and over again, and we miss, but we do it again, right? We don't quit. We keep going. I want you to apply the same kind of tenacity to the ultrasound, okay? Continuing to develop those skills. We're going to start out by building our confidence on older kids with bigger veins, and I want you to be confident or have some level of confidence when you go into finding that hard to find vein. Actually, hold on. And then, I want you to be a clinician. I want you to think about what you're doing. The vessel diameter, depth, location. We're going to start low in the arm. We're going to avoid flexion points, and we're going to stay away from the upper arm. Your path to certification. This was part of it. You either watched the lecture or you sat through it. you made it. We're going to get signed off in the skills lab or by Fran or I on an individual basis. And then in order to become proficient or relatively independent, you need to get signed off by someone on the ED team that is proficient at it and can proctor your first 6 ultrasound starts. So Fran or I, Aubrey, Ashcon, any of the attending, some of the fellows that are proficient at it, they can sign off on your attempts. Okay. Again, one more reminder, vessel preservation. These kids need that access for the rest of their life. Questions?
Dennis had one. He was wondering about using Jtip. Do you want to avoid going directly over the vessel like we do?
Right. So it's oftentimes the technique we'll use when we're using the superficial veins. Our Jtip will use a Z-trap method to pull the skin away from the vessel. We'll introduce the Jtip and then let it slide back over the top. That's one really good technique for avoiding vasoconstriction and blowing that vein. Like I said, you're going to use your clinical judgment. You're going to look how close that vein is to the surface of the skin. If it's running relatively deep, you're relatively safe to go right over the top of that. You're not starting. You're going to be, because your path through the tissue is a little bit further back. You guys, it's not a problem to start over the vessel. But again, you want to use your clinical judgment. If it's right there on top of the vessel, yeah, you might want to Z-trap.
Free lunch will be served.
Sam, you have a question?
Yeah, of course, sickle cell kids. I mean, are you essentially saying we should just put in 24 gauges in these sickle cell kids? Because,
free lunch will be served.
I mean, even when you get a 20-year-old, you're going to go gauge, just use a 24 gauge simply because
again,
the diameter of the vessel.
You look at the diameter of the vessel, use your clinical judgment. They're a greater risk for developing a thrombus. Okay. They're going to more likely to have scar tissuing or stenosis. And so use your clinical judgment. It's not, what's your goal? If you need fluid resuscitation, you may want to, go with something a little bit bigger, but you have to pay attention to what you've got in front of you and use your clinical judgment. I would go small, if possible, and then go up from there. Right?
When you said to avoid areas with those kids and others that have scar tissue and have stenosis, to differentiate that, does it look different or is it just a lack of compliance when you're applying pressure?
Sometimes it looks different. Sometimes you'll see a really thick wall and so you have a nice big round vessel, but with a really thick wall and a really small lumen. And so when I talk about exploring your vessel path, you might have at one point, you're like, oh wow, this is a beautiful vessel. But you go up, 2 or 3 centimeters, and you'll see that wall get thicker and thicker, and that lumen gets smaller and smaller. Okay, so that's why it's important to look at your path. So you want to look at the length of your path and the length of your catheter.
Atención a todas las
So
familias.
that you
Se les
feel
ofrecerá
comfortable
almuerzos
that
gratis
that catheter is going to have a nice
de las
clear path.
12 a la 1 de la tarde.
Get pretty good on time.
Por la casa, Ronald
Okay, so
McDonald.
the next portion is skills. Fran, again, and Ashcon, thank you. Ashcon helped with this process too. We have some really cool models that we're going to use to practice on. I'll be on this weekend, and so I'll have a couple with me. So if you don't get into one of the skill sessions that happens today, we can play around with them later today and this weekend if need be. So.
And then once you come to skills, I have for those that are on the call, once you kind of check off with Kevin or whomever, I have the proctored sheets that you'll just put the patient sticker. And again, it doesn't have to be a successful IV placement. Hopefully some will. But we want you to keep track and then let me know once you've done 6, then I will put you on the flow sheet that you can go ahead and do PIV, which will be available to charge nurses to know who can do this.
Let's check your passport. You need to get your stamps.
That's right, gotta get your stamps.
Is there any way someone could be trained as a proctor for night shift?
So you're asking me to stay over for an extra 4? And, yes, I think that's a great idea. I think we should just train up a champion, an ultrasound champion. That
Are you volunteering, Dina?
Yeah, I don't know.
Well, they were
a lot, but I'm kind
There
of
was a
surprised.
previous group that went through the IB class like 2 or 3 years ago. Miriam was one of them, Carrie. So maybe we can connect with them
Yeah.
and get them kind of back on the page.
Yeah, that.
And then they
and
could.
Carrie and I have done like some one-on-one sessions that we practiced, and so I'll talk with her too
Yeah.
about getting her to a point where she can kind of walk people through as well. Ashman, you had a question?
That was awesome, and I want to put you on the calendar for our fellows, but to teach. One question I had, and this is probably also a question related to IV placement in general, but with the 20 smaller gauge needles, like 24 gauge needles, do you find that you have to, like, one, you have only a certain amount of length because they're shorter, so you can't necessarily go as deep, but do you adjust your angle at all? Like, can you not go quite as steep because they tend to kink more? Or?
Exactly, yeah. So our regular 24 gauge catheters that we stock in the cart are 3/4 of an inch, and then the longer ones are 1 1/4 inches. So we got an extra 1/2 inch. So that allows us to maintain that more shallower angle when we're going for something a little bit deeper. But yeah, you want to be thinking about that. Like I said, your angle of insertion is going to change relative to where you're at in the skin and the vessel. Because, like you said, that catheter can kink. Okay, so you want to make sure that when you're getting close to that vessel, you want to start to shallow out. But you want to be thinking like, okay, how much catheter is in my tissue, and how much catheter do I have left to thread into my vein? Because again, the goal is at least 50%. That's the goal. If we get 50% under inside the vein, our likelihood of extravasation or dislodging that goes way down. Okay, those IVs tend to last longer too than our ones who are only getting a tip in there, and then it's like super fragile. Like, don't move that arm, right? Don't tamponade. That's a technique actually that I use. I actually do not tamponade when I do my ultrasound IVs, because you just work really, really hard to get that catheter in there. And sometimes you'll put a lot of pressure on there. When you put pressure on that, it's moving tissue relative to that catheter. You're increasing your risk of dislodging it or causing extravasation. So I will forewarn the patient and the family, like, hey, there's going to be a little bit of blood that comes out. You need to be prepared, right? And this is where your friend comes in or your setup comes in. You've got that catheter. You're going to pull it out. You're going to let it bleed a little bit. You're going to connect your hub. Okay, and that's okay. That's why you got that extra sterile gauze there to kind of wipe things up. All right, thanks guys, I appreciate it.